Welcome to Ortho Reports podcast. Today, we're diving into a really fascinating case from the Journal of Orthopedic Case Reports. It's all about a super complex knee problem that led to a surgical solution so unique it had actually never been reported before.
Just imagine this for a second. You're walking, maybe running, or even just bending your leg, and there's this constant fear in the back of your mind that your kneecap could just pop out of place. I mean, that's not just a physical problem, right? That's a huge source of anxiety that can totally limit your life.
Well, that was the exact situation for the patient in this case study. For 3 whole years, this teenager's life was basically defined by his right kneecap repeatedly and painfully dislocating. It was holding him back from doing pretty much everything, so the doctors had a real mystery on their hands. They had to figure out not just what was going on, but more importantly, why.
And let me tell you, this was not a simple, straightforward case. When the surgical team really dug in, they found a whole puzzle of 3 separate anatomical problems, all working together to create this massive instability.
Okay, to really get what was going wrong here, let's use a little analogy. Think of your kneecap, your patella, as a train. It's supposed to glide really smoothly in a groove on your thigh bone, and that groove is the train track. Now for this young man, there were huge problems with the alignment of the track, the actual shape of the track, and even the safety rails designed to keep the train on it. So the first problem they identified was a pretty bad case of genu valgum, which most of us know as knock knee. This misalignment basically meant the entire train track was crooked, and that angle creates this constant, unnatural pulling force on the kneecap, always trying to yank it off the rails to the outside.
And the numbers here really tell the story of just how severe this was. The Q angle, which is what doctors use to measure that pull, was a whopping 22 degrees. When you consider that the normal range is only between 13 and 18 degrees, yeah, you can see just how much extra force was constantly fighting to destabilize his kneecap.
But believe it or not, a crooked track was only part of the problem. Culprit number 2 was something called trochlear dysplasia. And what this means is that the groove in the thigh bone, the track itself, was way too shallow. So even if the alignment had been perfect, the train had almost no real track to sit in securely. And again, the numbers are just staggering. The depth of his trochlear groove was only 1.2 millimeters. To put that in perspective, a stable, healthy groove should be more than double that, over 3 millimeters deep. His was essentially a flat surface. It offered no bony stability whatsoever.
So you see, what we're looking at here was a perfect storm of instability. You had the crooked track from the genu valgum. You had the flat track from the trochlear dysplasia. And then the final blow, a torn medial patellofemoral ligament, or MPFL. Sticking with our analogy, the MPFL is like a critical safety rail, and his was completely snapped. No wonder the train kept derailing.
All right, so facing these 3 really severe, distinct problems, the surgical team made a pretty bold decision. Instead of planning for multiple surgeries over time, they decided to try and fix everything, all 3 issues at once in a single, groundbreaking operation.
And that, right there, is what makes this case so important. According to the authors, this was the very first time in published medical literature that these 3 specific procedures, to realign the bone, deepen the groove, and rebuild the ligament, were all performed together in one single surgery.
So let's break down this amazing triple fix. First, they performed a distal femoral osteotomy. That's where they actually cut the thigh bone to correct the knock knee and, you guessed it, straighten the track. Second, they did a trochleoplasty, carefully carving a much deeper, more stable groove for the kneecap. And finally, an MPFL reconstruction, where they used a tendon graft to completely rebuild that crucial inner safety rail.
Okay, so after an operation that complex and demanding, there's really only one question that matters, isn't there? Did it work? Let's take a look at the results. The anatomical changes they achieved were they were remarkable. You can see how successful the surgery was just by looking at the numbers. His femoral angle, that measure of alignment, went from totally abnormal to perfectly normal. The trochlear depth more than tripled, creating a nice, stable groove. And the sulcus angle went from nearly flat to a healthy V-shaped track. They fixed every single thing.
But, fixing the anatomy on an X-ray is one thing. What about real-world function? This chart shows the patient's Tegner Lysholm score, which is a standard way to measure how well a knee works. Before surgery, he was at a 51, a score that points to some major problems. After surgery, he shot all the way up to 94, which is considered an absolutely excellent outcome. And this, right here, is the bottom line. This is what it's all about. 1 year after that massive surgery, the patient had zero, not a single one, further dislocation. That constant fear was finally gone. He had a full range of motion and was able to get back to a normal, active life. The triple fix worked. It absolutely worked.
So let's zoom out a little. Beyond this one incredible success story, what can we learn from this? What does a case like this mean for the wider field of orthopedic surgery?
Well, the surgeons who wrote the paper state their main takeaway pretty clearly. They say that even though this combined approach is really difficult to perform, it can be a powerful and effective solution for patients who have this very specific, very complex combination of issues. It basically proves that in certain cases, tackling all the root causes at once is the best way to get a stable, functional knee. And that leaves us with a really fascinating question for the future, doesn't it? As surgical techniques get better and better, could this all-in-one approach become the new gold standard for other complex joint problems? This one single case suggests that, for the right patient, one big, comprehensive fix might be way better than a series of smaller ones. It's definitely a powerful idea to think about. Thanks so much for listening.